The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this episode of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and it's a pleasure to be hosting the podcast, and thanks to everyone for listening in. With a great deal of coverage in this podcast of late on the one big, beautiful bill passage and the impact to healthcare, I thought I would tell you a little more about other major developments over the past 2 months. In essence, other healthcare developments have been crowded out of the headlines by the one big, beautiful bill. These items may not be as watershed as the budget reconciliations bill's impact, but the announcements will have major implications for healthcare coverage and health plan finances. We'll take 3 breaks today to split the podcast up. I will cover 5 topics today. One long discussion will occur on prior authorization, and then we will conclude with 4 briefers on drug rebates, drug transparency, preventive services, and risk adjustment data validation audits in Medicare Advantage. I will discuss RADV very briefly, but I plan on an in-depth discussion on a coming podcast in the next few weeks. So let's get right into it before our first break. So again, the first item I want to talk about is prior authorization. And there was a major announcement on June 23rd, and health plans, in essence, preempted CMS action on prior authorization reforms with reforms of their own. For the past few years, the feeling has been palpable at health plans. State and federal regulators and lawmakers were tightening the screws on health plan prior authorization. And so to preempt further regulatory action on the issues, plans have agreed to make further reforms on their own. What changes are already in place? Well, on the Medicare Advantage front, the Centers for Medicare and Medicaid Services did a number of things on the PA front. For the past decade, the agency has honed its program audit protocols for both pharmacy and medical service requests and appeals. It spends a great deal of time on recent audits diving into the whole PA life cycle and digs deep on the application of medical necessity criteria for both pharmacy and medical services. It also finalized a significant interoperability rule that requires plans to adopt electronic prior authorization for medical services. This is meant to speed up approvals and better gather required information for the approval process. There is already strong EPA penetration for retail drugs. And last but not least, CMS initiated a new rule that went into effect on January 1, 2024, that requires MA plans to follow traditional fee-for-service coverage criteria. I have taken issue with this far-reaching change and argued that CMS is taking the managed care out of managed care. The new rule could explode MA costs over time by applying coverage rules from fee-for-service to a program that is meant to gatekeep unnecessary services. CMS is already auditing on the new rule, however so slightly right now. Other rules also clamp down on PA. On the Medicaid side, state Medicaid agencies are beginning to mimic what CMS has done on program audits in civil monetary penalties in MA when the plans do not act accountably. They must apply reasonable and consistent medical necessity criteria at the Medicaid program level too. The ever-growing regulatory oversight of Medicaid managed care plans stems from the Obama-era Medicaid Uber or Mega Rule, which seeks to establish strong oversight over Medicaid finances, operations, and quality, just as in Medicare Advantage. Then there are state laws around prior authorization too. States are limited in what lines of business they can impact due to ERISA self-insured and Medicare preemption at the federal level. But state PA laws can be applied to full risk commercial coverage as well as Medicaid. States are mandating PA transparency, electronic processing, and even gold carding requirements. Health plans do practice gold carding, which awards trusted provider groups the privilege of lighter PA scrutiny or provider control over most of what they furnish, often in delegated risk situations. But what the gold carding states have approved is quite different. In these laws, any network provider that reaches a threshold approval rate over time must be freed of PA by any health plan. With that intro on prior authorization that has already been instituted, we will take our first break and come back to discuss what prompted the health plan proposals and what they committed to. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back to this episode of the Healthcare Labyrinth Podcast. We are talking about various major developments in healthcare that were crowded out of the headlines by the big, beautiful bill. We promised to continue our discussion on the prior authorization announcement from health plans. So what prompted the plan's proposal on prior authorization? Well, at their confirmation hearings, both Health and Human Services Secretary Robert F. Kennedy Jr. and Centers for Medicare and Medicaid Services Administrator Dr. Mehmet Oz agreed that PA was out of control and they would seek to institute reforms. Dr. Oz was perhaps the most emphatic on this. At his hearing, the CMS administrator actually laid out his ideas to streamline the number of services to which PA would apply and ensure uniformity of medical necessity criteria across plans and Medicare Advantage. Oz was rumored to be readying his own proposal and rule for PA before the health plans came out with their proposal in a joint meeting with Kennedy and Oz recently. Further, regulatory and lawmaking actions continue to make ground. State PA laws continue to be proposed and enacted. A perennial prior authorization reform bill for MA amasses more and more support each year in Congress. In the past, the measure was too expensive to pass. Much of it has now been implemented via rule, and the bill is now scored as no cost. A bipartisan group of lawmakers would like to pass it so the rules reforms cannot be undone by an administration in the future. So what have the health plans proposed? About 50 health plans, including some of the biggest and representing as many as 75% of America's insured, met with Kennedy and Oz recently to outline their agreed-upon efforts on PA across all lines of business. Prominent insurance trade groups, AHIP and the Blue Cross and Blue Shield Association were also present. The PA plan from the insurer centers both on PA and claims denials. Health plans committed to reducing the number of service codes subject to PA and to establish a standard framework to increase how many authorizations are adjudicated electronically and in real time. PA changes begin as of January 1, 2026, with the electronic framework on January 1, 2027. The plans will also increase education on the PA and appeals process, overall accountability, and transparency around denials of PA claims PAs and claims. Plans will also honor PAs for 90 days when a consumer changes health plans. The reforms look a lot like what Dr. Oz committed to at his confirmation hearing. They cover streamlining processes and what is subject to PA, but do not commit to uniform review standards. The federal government will forestall any of its reforms as it monitors the changes the health plans are making. CMS could make changes if the initiatives do not meet expectations. At the same time, Oz says this is a first step, so some regulatory action in the future is likely. So what was the provider reaction? Major provider organizations welcomed insurers' pledge to reform PA, but they generally kept their powder dry to see what actually happens. They note that health plans have promised changes before, including a similar 2018 commitment, only to not deliver on promises. They also say many PAs will remain. Another analysis suggests that the real impact on plans may be minimal, as any increased cost from the loss of PA use would be passed on as higher premiums. However, the tech investment promised by plans in electronic PA would be meaningful. It is fair to say that the proposed plan reforms, as well as the ever-evolving changes coming from state and federal lawmakers and regulators, will mean meaningful relief for providers. Providers admit that if plans follow through, it could mean major savings. Whether that is in the end a good thing for our system is another matter. Again, I believe a carefully crafted and accountable PA program in managed care is important to cost restraint. Some of what the plans have proposed and even what lawmakers and regulators have enacted are at core reasonable, but others, such as the 2024 MA rule, which mandates the use of fee-for-service criteria, are clearly misguided and will lead to higher costs. We will take our second break at this point, and when we come back, I will comment on my wish for site-neutral payments and what the plan impacts may be from their PA commitments. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back to this episode of the Healthcare Labyrinth Podcast. We are talking about various major developments in healthcare that were crowded out of the headlines by the big, beautiful bill. I wanted to close out the PA discussion with a mention of site-neutral payments and the overall impact of PA changes on health plans. Then we will get to some other healthcare developments. It is my hope that regulators and lawmakers will look at site neutrality next. If regulators and lawmakers have been convinced that PA is wasteful and a huge administrative burden to providers, the same can be said of the lack of site neutrality payments in Medicare. Plans, employers, government programs, and consumers, in the form of exorbitant cost sharing, pay hospitals and their other own settings a premium when the same services are rendered at much lower cost at physician offices and other freestanding ambulatory centers not affiliated with hospitals. Tens of billions, if not hundreds of billions, could be saved each year in Medicare, fee-for-service, and MA, and the commercial lines of business each year with site-neutral reforms. The lack of site neutrality is one of a number of factors driving a crisis in the employer healthcare sector because their rates are based on Medicare ones. So what will happen to plans financially due to their PA commitments? Well, plans have to be a little worried about trends in PA and even their own proposals. Yes, electronic prior auth and the reasonable use of AI could reap major administrative savings and even identify aberrant clinical patterns not seen by human medical directors. But utilization management has been the cornerstone of cost savings for health plans for decades. Giving it up substantially when many plans have yet to truly pivot to ongoing care models, analysis, and member and provider engagement is clearly risky. It becomes yet another headwind for financial performance, like the utilization surge, risk adjustment and overpayment reform, poor quality and star results, and more. So as much as plans will invest in building a coherent and standard electronic PA infrastructure, they too need to continue making investments in risk, cost, and quality analysis, as well as member and provider engagement. So that's our PA topic and what health plans committed to. Let's go to our next major healthcare development. It happened on June 24th, where it covered drug rebate elimination. Fresh from the agreement with health plans to move forward on major PA reform, CMS Administrator Dr. Mehmet Oz said he wants pharmacy benefit managers to end the complicated system of drug rebates, or the government will step in to change it. Oz said regulators and lawmakers could revamp the system, quote, fairly expeditiously, unquote, because there is widespread support. Under Trump 45, the administration did propose to eliminate the safe harbor that allows the paying of rebates in Medicare. And that could certainly be something that Oz puts on the table if PBMs on their own do not fundamentally change with drug makers the rebate program in retail and other drugs. The next major health development happened on 6/25 on drug transparency. Again, CMS Administrator Dr. Mehmet Oz hinted that the Trump administration could issue a rule that is focused on drug price transparency. This could be part of the administration's overall drug price reform initiative, which has come in two very good executive orders. The rule might require healthcare companies such as health plans and pharmacy benefit managers to disclose the net prices of drugs. It could also force every stakeholder in the drug channel to do just the same as well. With that, we'll take our last break, and when we come back, I will comment on the last two major developments in healthcare. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back to this episode of the Healthcare Labyrinth Podcast. We are talking about various major developments in healthcare that were crowded out of the headlines by the passage of the Big Beautiful Bill. I wanted to close out on two last developments. The first one is from June 27th. As expected, the Supreme Court ruled 6-3 in favor of allowing preventive services to continue under the Affordable Care Act. The majority was a mix of conservatives and liberals. The High Court determined that members of the U.S. Preventive Services Task Force, which makes recommendations for coverage requirements under the ACA, are selected within the bounds of the Constitution. The court agreed that the task force is appointed by an executive appointee, in this case the HHS secretary, and could be replaced at any time. The religious arguments on the provision of certain services were largely sidelined in the decision. While some services are controversial, the mandate in my mind is a good thing, as it encourages and makes affordable preventive health screenings for all Americans. And so the last major development was the announcement of risk adjustment data validation audits in Medicare Advantage in late May. In a bombshell announcement, beginning immediately, the Centers for Medicare and Medicaid Services will audit all eligible Medicare Advantage plans for each payment year, beginning for payment year 2019, and invest additional resources to expedite the completion of in-flight audits for payment years 2018 through 2024. This amounts to 100% RADV audits each year for every contract moving forward. Key elements of the plan include enhanced technology for medical record review to flag unsupported diagnoses, and a major workforce expansion to boost medical coders from 40 to 2,000 by September 1. CMS says it will be able to increase its audits from about 60 MA plans a year to all eligible MA plans each year in all newly initiated audits, approximately 550 MA plans. The CMS press release uses this rather inexact terminology of plans. A quick review suggests that the 550 number, purported to cover 100% of plans, represents a subset of H contracts relying on risk adjustment, not certain pilots, that were in effect as of 1/1/24 or before. The coders will manually verify flag diagnoses to ensure accuracy. It will increase reviews from auditing 35 records per MA plan per year to between 35 and 200 records per MA plan per year based on the contract size. In mid-June, CMS announced the first 45 contracts to be audited for payment year 2019. In late June, it announced round 2 for payment year 2019 has 310 more contracts. That means that almost 50% already have audit notices. To say the least, CMS's approach to RADV will be controversial. That's the case as well for the RADV rule finalized during the Biden administration in 2023 that will be used to conduct the audits. Stay tuned on an in-depth dive into RADV and the announcement in an upcoming podcast. With that, we will conclude this edition of the Healthcare Labyrinth Podcast, and we'll see you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.